Well, purple slide adrenergic agonists. Adrenergic drugs of some variety have been around for decades, starting with epinephrine itself, which had a host of topical and systemic side effects, including hypertension and tachyarrhythmias and other things. And I throw this slide in because you still may see people who were on epinephrine years ago and have these adrenochrome deposits that look like a melanotic malignancy of some variety. So if you see lesions like this in an elderly patient with a long history of glaucoma, ask them about the use of epinephrine. A prodrug called dapivirine or propine got rid of most of the systemic side effects, but not the topical side effects. We now use selective alpha-2 adrenergic agonists, aproclonidine and brimonidine. But despite changes in formulation and changes in preservative, topical side effects remain problematic. Their mechanism is a little vague. They decrease aqueous production and increase aqueous outflow. And it's not 100% sure where the aqueous outflow is. I believe it's more likely to be ciliary body than trabecular meshwork, but it's not entirely clear. Like the beta blockers, the beta adrenergic antagonists, this family of medications do not work well at night, and so that's a problem. They're indicated for all forms of glaucoma. There is some evidence, I'm underlying some with my voice here, of neuroprotection in the LOGIT study for normal tension glaucoma. The adrenergic agonists were more effective than beta blockers, and there have been animal studies that have shown some neuroprotection. For me personally, it's not compelling evidence that these are neuroprotective agents, but may be better to use in normal tension glaucoma than using beta blockers, perhaps. Contraindication is babies. Never use brimonidine in a baby or a young child. It can be fatal. It can cause respiratory arrest. So just to say that again, and I'm sure I'll say it one more time. Aproclonidine is safer for little babies because it doesn't cross the blood-brain barrier. Alpha-adrenergic agonists should not be used in patients on monoamine oxidase inhibitors. They have the most side effects, topical side effects, of any of the topical agents. Hyperemia, follicular conjunctivitis. So this is a follicular reaction that's pretty typical of adrenergic medications. And in my experience, if somebody comes in on a prostaglandin and a beta blocker and an adrenergic agonist and a topical carbonic anhydrase inhibitor and has an eye that looks like this, it's almost always the alpha agonist that's doing this. You can have periocular erythema, and you can really have pretty profound topical allergy to this medication. Systemic side effects are uncommon. Somnolence can occur occasionally, although I've really not seen that very much. And again, respiratory depression in babies. Purple cap usually, aproclonidine or iopidine is very rarely used chronically because patients become sensitive to it and have a topical reaction to it. It was used primarily to prevent pressure spikes with trabeculoplasty and iridotomy, and really changed the face of those procedures. Most of us now use brimonidine because it's around, and it's also available as a generic in the U.S. There is a combination called Combigan, which is brimonidine timolol. Really important that you remember what's in these medications. I've seen one small baby who was put on Combigan by a doctor who would never have thought to put the baby on bromonidine. But we sometimes forget what's in these combination drugs. Both aproclonidine and bromonidine are either used 2 or 3 times a day. You really don't get a lot of extra punch from going from twice a day to 3 times a day. So don't make that move thinking you're going to get 5 millimeters of mercury pressure lowering. You might get 1 or 2. The combination of bromonidine and timolol is a twice-a-day agent. So the key points here about adrenergic agonists: they act on both production and outflow of aqueous. In my experience, they have by far the most topical side effects of any of the drops that we use for glaucoma. And they are contraindicated in babies and young children. And when I say they, I mean bromonidine and Combigan you should not use in babies and young children. Aproclonidine may be safer, and I have used that in young people because it doesn't cross the blood-brain barrier.